This is a 42-year-old female with history of left eye open lobe injury with traumatic cataract, for which lens extraction was done 14 years ago and was left aphakic. Now the patient had come for secondary IOL surgery. A 3.2 mm primary incision and side port were made, and visco was injected very slowly so as not to disturb the anterior vitreous face. Here we can see a fibrosed posterior capsule, an absent ALC, and a corneal scar. For this patient, simply placing an IOL in the sulcus has a very high chance of IOL decentration post-operatively. So, we decided to do a PC rhexis and place the IOL as optic capture under the PC rhexis. With the bent cystodome, a small nick is made on the posterior capsule. Then, a rhexis of around 5 mm is made. Here we aim to make a smaller rhexis so that we could do an optic capture under the PC. Doing rhexis in a fibrosed capsule is challenging, and care should be taken to avoid pulling at the fibrotic areas, as it could lead to complications like zonular dialysis. Viscoelastic is injected very carefully so as not to disturb the anterior vitreous face. Here we use 1/2 scissors to make a nick on the other side, and then the rhexis is completed. A 3-piece foldable IOL is loaded into the cartridge. While doing so, the cartridge is slightly flexed and the optic is slid in through the groove into the chamber under visco cover. The trailing haptic is left outside the chamber and the cartridge is loaded into the injector. Care is taken that the trailing haptic is within the injector and not lying over the edge. Make sure that the piston of the injector is not engaging with the trailing haptic and causing it to get crushed. The screw is rotated till the leading haptic reaches the tip of the cartridge. The cartridge is then introduced bevel up, and once it is well inside the eye, the screw is rotated clockwise to start ejecting the IOL. This is done slowly to place the leading haptic in the sulcus. Then the shaft of the injector is twisted anti-clockwise to prevent the IOL from rotating and causing injury to the PC. The IOL is dialed to position the haptics in the sulcus, and then the optic is pushed underneath the PC. In cases where the PC is not intact and the vitreous is exposed, visco wash should be done very carefully so as not to disturb the anterior vitreous face. We prefer to inject PSS manually as opposed to using an irrigation aspiration cannula or a coaxial probe, because you have more control over the process when done manually. The key is to always keep the AC maintained. It should not get too shallow or too deep at any point of time. This step will flush out most of the visco except that at the angles and under the endothelium. The optic is then tucked back under the PC rhexis. The remaining visco is then removed using Simcoe with irrigation on through the main tunnel. While flushing, simultaneously one must also depress the tunnel slightly so as to maintain the pressure inside the AC and prevent the vitreous from getting hydrated. To remove the visco from the endothelium, it is better to flush than to aspirate, especially in this case, so as not to create a vacuum which could cause shallowing of the AC. As mentioned earlier, the key is to avoid making the AC too deep or too shallow at any point of time. The incision and side port are sealed by hydration. And intracameral moxifloxacin is injected.